Well, welcome everyone to joining forces, working with consumer advocates to promote integrated care. This is a webinar co-sponsored by the Hartford Change AGEnts Initiative, Community Catalyst, and the John A. Hartford Foundation. My name is John Bielenson from Strategic Communications and Planning, and I'm also a lead consultant on the Hartford Change AGEnts Initiative, and I'll be your host this afternoon. Today we're really pleased to present a third in the series of webinars sponsored by the Hartford Change AGEnts Initiative that will focus on how geriatrics professionals can connect with consumer groups and amplify their advocacy on behalf of low-income older patients and particularly dual eligible Medicare, Medicaid beneficiaries. To tell us about that topic, we have two excellent presenters. The first is Renée Markus Hodin, who is the Director of Voices for Better Health Project. Renée leads efforts to bring a consumer voice to the design and implementation of new programs aimed at providing better coordinated, comprehensive, high-quality care to dual eligibles. Her expertise extends to other areas in healthcare, including hospital-free care and community benefits and healthcare conversions. Before joining Community Catalyst in 1998, Renée served as Special Assistant Attorney General in the Civil Litigation Department of the Vermont Attorney General's Office. She holds degrees from the State University of New York at Binghamton, and the University of Maryland School of Law. And joining Renée, actually, folks, can we ask you to mute your lines, please? And in fact, we may have to mute everybody here just because of this ambient noise. See if I can find now. I can't find the offender here. I think we're all right. All right. Well, again, I'm pleased to actually welcome Gregg Warshaw, Dr. Gregg Warshaw, who is the Director of the Office of Geriatric Medicine at the University of Cincinnati College of Medicine. He's a professor in the Department of Family Medicine and the Martha Betty Stemmons Professor of Geriatric Medicine, directing the Geriatric Medicine Fellowship Training Program for Physicians at the University of Cincinnati. He serves as Medical Director of Maple Knoll Village, a continuing care retirement community in Springdale, Ohio, and is the past President of the American Geriatric Society and the Association of Directors of Geriatric Academic Programs. Dr. Warshaw is also a 2013 Health and Aging Policy Fellow. So welcome to Renée and to Gregg. Today our agenda includes, again, some of these welcome and introductions. Renée will then do an overview of Community Catalyst and of the CMS Duals demo and Voices for a Better Health project. Gregg, Dr. Warshaw will talk about his experience in Ohio and the work that's going on there, and then we'll have some questions and discussion. But before we get started, I'd like to turn it over to Markus Escovedo of the John A. Hartford Foundation, who is program officer there and, again, one of the leads on the Hartford Change AGEnts Initiative. And he's going to tell us just a few minutes on the Hartford Change AGEnts Initiative and provide a little frame for today's webinar.
Thank you, John, and a warm welcome to everyone today from the John A. Hartford Foundation.
The conference has been muted.
Oh, shoot.
Decades of primarily supporting academic researchers and educators in geriatric medicine, nursing, and social work, today the Foundation is helping put geriatrics expertise to work to change healthcare and improve the lives of older adults and their families. The Hartford Change AGEnts Initiative, a partnership with the Gerontological Society of America and a team of leaders, is our signature interprofessional effort to leverage the Foundation's most valuable assets. And that's not our money. It's the thousands of scholars and grantees, as well as the mentors, advisors, and supporters of any current or past Hartford-funded projects, all of whom are invited to become change agents. The initiative aims to support the community of change agents who can learn from and support one another and work directly on changes in practice and service delivery that will improve the health of older Americans. By becoming a part of the Change Agents community, you have the opportunity to access a variety of career and leadership development activities through an online community platform with a searchable database of change agents, and we do encourage each of you to build a profile and begin connecting. We have small grants programs to support promising practice change ideas, and a rich array of conferences and skill-building trainings, consultancies, and webinars such as this one that we are pleased to offer today in collaboration with another Hartford-funded project, the Voices for Better Health Initiative. For more information and to become part of the Change Agent community, to build out your profile and learn about future opportunities, please visit changeagents365.org. And now I'm pleased to turn it over to a change agent herself, Renée Markus Hodin, Director of the Voices for Better Health Initiative at Community Catalyst.
Thank you so much, Markus. I'm really glad to be here, and I'm very grateful to the Hartford Foundation and to the Change Agents Initiative for partnering with us on this project and on this webinar today. Let me first tell you a little bit about Community Catalyst. For those of you who don't know us, we're a Boston-based nonprofit healthcare advocacy organization that tries to bring the consumer perspective to healthcare decisions wherever they're being made. We do our work primarily through a network of advocates in about 40 states. These are advocates that work at the state level as well as the local level. And through that work on a wide variety of healthcare issues, everything from Medicare, Medicaid, dental access, children's health, etc., we're trying to build a stronger advocacy infrastructure in order to, again, have that strong consumer voice at the table where those decisions are being made. We also lead broad-based issue campaigns like the Voices for Better Health program that I'm going to be talking with you about today. But before we get there, I wanted to just set the stage a little bit to talk about some demonstration projects that John mentioned in the introduction. These are demonstration projects related to people who have both Medicare and Medicaid, often referred to as dual eligibles, which isn't, of course, a great term, but for shorthand we'll use it today. So without going into too much detail, I think most of the people on this phone know that, that people who have both Medicare and Medicaid, and there are about 10 million of them now, tend to have lower health outcomes and, quite frankly, are an expensive population overall. And so to address these sort of twin problems of cost and quality, the Affordable Care Act created two key offices that are relevant to the conversation today. One is the Center for Medicare and Medicaid Innovation, which is charged with identifying and testing new ideas for improving care and stabilizing costs for Medicare and Medicaid beneficiaries and for the programs overall. And then another office, the Medicare and Medicaid Coordination Office, sometimes known as the Office of the Duals, which is focused on that population of people who have both Medicare and Medicaid. And together, these offices are working and have created an opportunity for states to develop a new approach to pay and deliver care to dual eligible beneficiaries. They released this opportunity back in 2011, and over half of the states, about 26 states in fact, proposed to create a program in different ways to improve the care for folks in their states. They were given two financing options, and most of them chose the managed care option, though a few are pursuing a slightly different option that would allow states and the federal government to share in any savings. So here's a picture from thanks to the Kaiser Family Foundation, which updates this regularly. This is as of last month, but I believe it's still current as of today. Here's where we are today. There are 12 different states that have reached agreement with the federal government for their dual eligible demonstration projects. And 6 have in fact launched those and are starting to enroll people. Several, as you can see from the map, several are still pending. Now I mentioned before that again most are using a managed care approach, which means that more money and more responsibility is being placed onto plans, which there are then both risks and opportunities. The risks are, in a shorthand way, that we return to sort of a 90s style managed care, and this is about kind of making money. But the opportunities are great. They are about building out models that we know work, and at bottom, measurably improving the lives of the older adults and people with disabilities that will be subject to these demonstrations. So now I'm going to turn to tell you a little bit about what we're doing here at Community Catalyst through the Voices for Better Health project to both mitigate the risks but also take advantage of the opportunities. So with initial funding from the Atlantic Philanthropies, we created Voices for Better Health at the beginning of last year. And there are two goals for this project. One is sort of a policy goal, which is to shape the design of the demonstrations so that they meet the needs of dual eligible older adults to have a better quality of life. And the second one is more at the delivery system level or the organization level, health plan or provider group. And that's to establish an ongoing and meaningful, strong voice for dual eligible older adults and caregivers in order to continuously improve quality and practice. We're working nationally to shape the demonstrations, but we're also, we have a targeted approach by working with advocacy groups in 5 different states, in Michigan, New York, Ohio, Washington, and Rhode Island. We're providing both subgrants and support to organizations who serve as lead organizations but who are putting together coalitions of disability and senior groups and others to work to be at those decision-making tables with policymakers and plans to shape the design and then also the implementation and rollout. I'm not going to go through this long list of bullets, but really this is up here to say that there are just a lot of moving parts. There are a lot of complicated issues, everything from enrollment to assessment, to quality measurement, to appeals and grievances, and so on. And then, of course, those are just large buckets for much more detailed conversations about how to make design a program that will work to both achieve the goals of the program overall, to improve care for folks, but also to stabilize costs. And quite frankly, any of these could make or break a demonstration. So that's why advocates are so engaged in trying to bring a consumer perspective to the table to be sitting with the other stakeholders that matter. The other thing we're trying to do nationally is to convey a vision, I suppose, of what good care looks like, what comprehensive, coordinated, and continuous care looks like. So this is a shot from a video that we put up, for instance, in which we talked about an older adult and her daughter who live here in Massachusetts and a model of care that has worked for them. Now, our advocates certainly know policy and politics, and particularly the politics on the ground. But one of the things that they don't have a deep knowledge of is the best practices of caring for older adults. And that's where our project with the Hartford Foundation comes in. So through this new grant from the Hartford Foundation, we're building a sort of a powerful marriage, if you will, of the policy and politics on the one hand, which comes from the consumer advocates, with the best practices and on-the-ground knowledge of what works for older adults that comes from geriatric providers. So essentially, we're trying to infuse the advocacy work of the Voices for Better Health advocates with the know-how of the geriatrics world. We think that there are many, many areas that geriatric providers can help out with, but there are some priority areas that we think that are really ripe for collaboration, and that includes things like assessment. So, medical, functional, psychosocial, and safety components of an assessment that works for frail older adults. What good care coordination and care teams look like, how care teams can work together. the workforce issues. So what types of providers are needed to best serve this population, both the clinical and non-clinical. On the long-term services and support side, we think that geriatric providers across the spectrum, across the disciplines, have a deep knowledge about what the intersection is of both the medical and non-medical sides. And then quality measurement. We believe that working together, advocates and providers can identify the measures that really matter most to older adults and their families. So what are we doing? First thing we did was to meet up with Dr. Gregg Warshaw, and you'll be hearing from him later. Gregg has been an invaluable national advisor to us here at Community Catalyst in terms of overall guidance and outreach to the community of geriatric providers. We're also pairing our advocates in each of the states with 2, and in one case 3, geriatric providers in a formal way, so that they work together on what needs to be done in the state. So I'll go through kind of quickly, but just to give you a flavor of who's working with whom. So in Michigan, where our lead organization is the Michigan Consumers for Healthcare Coalition, they are formally working with Maureen Mickus from the Western Michigan University and Dr. Terry Biggs from Hospice of Michigan. In New York, our lead organization, the Medicare Rights Center, is working jointly with Dr. Audrey Chun from Mount Sinai and with Tara Cortez, a nurse and the executive director of the Hartford Institute for Geriatric Nursing. And I might add a health and aging policy fellow this year. In Ohio, our lead organization, UCAN Ohio, is working not only with Dr. Warshaw, but with also Dr. Donald Mack and with Denise Brown, who's a certified nurse practitioner. In Rhode Island, the Senior Agenda Coalition of Rhode Island is partnering with Dr. Richard Besdine from Brown and with Martha Watson, a nurse who's an advanced practice nurse manager at the Miriam Hospital. And finally, in Washington, our lead advocates there, the Alzheimer's Association of Central and Western Washington, are partnering with Drs. Lee Burnside from Harborview Medical Center and Dr. Angela Hansen from Puget Sound Healthcare System. And again, they each are doing something slightly different. In New York, for instance, just about 2 weeks ago, they were together meeting with the state to discuss how to build care teams at work. So they're really getting into it already, working with policymakers and informing each other's work. I wanted to highlight a couple of other things that we're doing aimed at some strategies aimed at elevating the work of leaders in the geriatrics world. So this is, we put out a biweekly newsletter called the Dual Agenda, which provides updates on the dual eligible demonstration projects as well as kind of news that's relevant to the design of those demonstrations and to the population as a whole. And about 5 months ago, we started including a column written by leading providers. And you'll see we started off, of course, with an inspirational piece by Dr. Warshaw, followed by a piece on the GRACE model, from Steve Council, and palliative care from Dr. Diane Meyer, a piece from the good folks at Alterum on Medicare and communities, and then just last week, a piece on health confidence from Dr. John Wasson. And I'll just mention a couple of other things that are coming up that are of interest. We are working with the American Geriatrics Society to develop a set of webinars that will be focused on an audience of plans and providers that will happen this summer and will be focused on good geriatrics care. What does that mean? So we'll start off with an overview, we'll move into assessment, and then we'll start talking about care transitions. Another effort, which we're doing in partnership with the Elder Care Workforce Alliance, is to develop a video and toolkit to demonstrate in greater detail what good geriatric care looks like. And that should be done by this fall. So I want to close by just going to the next slide, first of all. Oops, one last. Okay, there it is. I just want to close by saying that, as this slide says, your voices matter. And why? It's because you have the deeper understanding of geriatric competencies and the importance of care coordination and interdisciplinary teams. And quite frankly, low-income older adults in this population really need advocates who know the policy and politics, that are working in collaboration with folks that have the clinical and non-clinical know-how. And there's many ways that you can pitch in to help by educating advocates and a broader community about what good geriatrics care looks like. You can use that knowledge to advocate for policy changes as these demonstrations start finishing their design and also going into their implementation, working at promoting practice changes at the plan or provider level, and more broadly participating in a learning community of like-minded advocates and geriatrics providers. So with that, I'll stop and turn it back over to John.
Well, thank you very much, Renee. And in fact, we'll, following the webinar, we will be sending out an email to all the folks who registered about a link to the newsletter, the Dual Agenda newsletter, which is excellent, and ways that folks can get involved with the learning community and with and other activities in the project as well. So thank you, Renee, for that review. Now, before we turn it over to Dr. Warshaw to give us a case study of sort of provider-consumer partnerships in Ohio, we wanted to actually take a pause here and ask folks to take a brief poll. It's actually just one question, but just give us a sense of sort of where you are and actually help Dr. Warshaw, kind of slant it or put his presentation at the right level. So to give us a little sense of sort of how much do you know about efforts to improve care for dual eligible beneficiaries, either in your state or more broadly. And if you want to just click one of those answers and then hit submit, that would be great. You should be able to see a very colorful slide. You can see that it's very exciting for me, at least. Maybe I'm easily entertained, but you can see the results come in real time. And let's see. We've got 18. We have 32 people voting. We've got actually 46 people on the call today. So again, nice turnout. Anybody else want to add into the responses here? All right, so it looks like we have actually about a third of the folks, a little more than a third of the folks that are very active on the issue. So we have a fairly knowledgeable group, Gregg, and then we have actually a pretty big middle group that knows something about the effort as well, but still about 20%. Or 17% of folks that are interested in sort of getting to kind of building their knowledge from a fairly basic level. So again, a broad group, but again, I guess a fairly informed one as well. So thank you for folks for taking the poll. And without any further ado, I'll turn it over to Dr. Warshaw, who will tell us a little bit about a case study of provider and consumer partnerships.
Thanks, John. And thanks to Hartford for hosting this webinar. The opportunity I've had to work with Renee and with her colleagues, including Carol Reagan, has really been wonderful for me, and I enjoy the opportunity to tell you a little bit about what this has been like for me. I think as clinicians, we understand the problems with delivering good care to older adults. Renee mentioned the cost-quality concerns that states and the federal government have about the care for particularly frail older people and people living in the community. I think the goal of the integrated care demonstrations is really to try to address some of these care issues and control costs. One of the things that I was not fully aware of before I started learning about the dual eligible population was how diverse it was. I am familiar with the patients I take care of who are generally older, but many of you may already know that many of the dual eligible beneficiaries in the Medicare and Medicaid program are under age 65. And the vast majority of the dual eligible population lives in the community. And mental health problems are a major part of the mix of clinical challenges that this population has, in addition to multiple chronic conditions. Another thing that was familiar to me and really fits with my experience in practicing geriatric medicine is that there is a subset of the dual eligible population that uses far more resources than other parts of the population. So there are some very well dual eligible beneficiaries who live in the community, many who are older, who really do not require a lot of healthcare services or long-term care services. On the other hand, there's a percentage, a smaller percentage that use quite a few resources. So how did I make my way into working with Community Catalyst? I had been doing my usual academic geriatrics work and working in sites where I care for dual eligible patients, and I heard that Ohio was going to engage in this demonstration. That we call it a demonstration, but it's actually a big change in the healthcare system. Every single one of the Medicare and Medicaid patients in my community, except for a small number of exceptions, are going to be part of this demonstration. This is not a sample or a small demonstration. This is 20,000 people in my area that are going to be involved. So I didn't know much about what was going on, but I thought it sounded like something geriatrics should be engaged in. So I called the AGS to learn more, and Nancy Lundenberg at the AGS said, you ought to talk to Renée, Markus, Hodin in Boston. Didn't know much about Community Catalyst, hadn't heard about it. And I had a good conversation with Renée, and then she referred me to our organization in Ohio called Universal Healthcare Action Network, which is a advocacy organization to improve care, particularly for low-income Ohioans. It's led by a dynamic woman, Kathy Levine, who's just an amazing person. Once again, I did not know about this organization. I've lived in Ohio for 29 years. I didn't know about it. So I'm not that politically engaged, but I found out that this was a great group to work with. Part of the impetus for me applying for the Health and Aging Policy Fellowship, which I did do in 2013, was to see if I could learn more and engage more in understanding how this demonstration got started and how it might be implemented. So in Ohio, I've had the opportunity by partnering with my colleagues in Ohio in the advocacy organization to attend meetings with the Medicaid office, with the area agencies on aging, with the health plans that are participating in the project, and with providers, and starting to learn more about some of the advocates in the disability community, which I did not have that much familiarity with in the past. With my time in Washington, I've been able to meet the people at the Duals office as well as in CMS who are doing the quality measurement work around this population and are implementing these projects. And it's given me a good opportunity to look at how a policy that's developed fairly distant from Ohio actually is implemented and starting in a state, and it comes all the way down to the patients in the retirement homes where I work are affected by this. So it's an amazing process to watch. As Renée has mentioned, these demonstrations are to test integrated care and financing And in Ohio, we went live in May 2014, and it's a 3-year project. And this is a federal, state, and health plan partnership. In Ohio, the state has chosen to develop the project in the urban areas of Ohio. I'm in Southwest Ohio. As I mentioned, there's about 20,000 dual eligible beneficiaries that will participate in Southwest Ohio. Throughout the state, over 100,000 people will be participating in this project. The scope and size of it is really remarkable when you think about how much money is involved. The state organized this around regions, and they've had to work with CMS and health plans to come up with contracts to make this all work. In Ohio, it was required, first of all, in Ohio, this is for all ages, over and under 65, and it includes a requirement was that there be at least 2 health plans participating in each of those regions. So where I am, 2 health plans, one run by Aetna and another run by Molina, are available to dual eligibles in my community. Other parts of the state, we have United Healthcare involved, CareSource, Buckeye, which is a local managed care plan. So we have several insurance companies. They bid for the opportunity to do this. They were recruited by the state, and they recognize that this is an opportunity for them not only to improve care, but also to have a lot of cash flowing through their businesses. We have a rolling start in Ohio going from region to region. My region came on June 1st. Part of the complexity of this is my state Medicaid office is not really familiar with working with the Medicare side of CMS. So it's been really hard for them to work out all the details with CMS. And so the Medicare part of this plan will be delayed until 2015. The way this works under the federal rules is that the Medicaid part is required. Everybody will be automatically enrolled in one of the Medicaid plans. They can choose which plan they want, but they're going to be enrolled in one of them. There'll be passive enrollment into Medicare in Ohio starting on January 1st, 2015. And that means if people do not do anything, they'll be enrolled in the same plan as the Medicaid plan that they're currently going to be in. It is possible for clients, beneficiaries, to opt out of the Medicare side of this demonstration. Under law right now, you cannot require Medicare beneficiaries to participate in managed care. I think it's going to be good for people to try out the plans for a while and try this integrated care demonstration. But if it's not working for somebody, they can opt out of the Medicare side. This is a capitated plan in Ohio. There's some withholds involved, but insurance companies are taking significant risk. They're going to be required to put together care plans and that incorporate client and family goals. And there's some state evaluation activity, but there's also a national contracted evaluator by CMS, which is the Research Triangle Institute. So what's the promise for beneficiaries and providers in Ohio? Well, they're promoting the idea that this will be an opportunity for dual eligible beneficiaries to have a single point of contact into the healthcare system. They'll just have one ID card that will represent all of their healthcare benefits. There'll be a 24-hour-a-day, 7-day-a-week nurse advice line that the plans will manage, and people will be able to call and get help anytime. There'll be the evaluations. There'll be opportunities for home visiting, wellness services, and we hope better management of transitions of care. So why should I, as a geriatrician in Cincinnati, get engaged in this? This is an amazingly disruptive demonstration, and I feel that's good because I think the current system is really pretty broke. So why not just break it completely and try something new? And I like it. I'm excited about it because it involves a large number of people, so we can really have scale in this thing. We know some models that work, like the PACE model. But whether you could expand the PACE model or some benefits like the PACE model into a large group of dual eligible beneficiaries in a plan that's run by a for-profit insurance company is a mystery to me. I don't know whether that can happen or not, but it's something that I'm excited to see whether we can have some influence on. The other thing that really struck me and still is striking to me is that as I go around and talk to geriatricians and primary care physicians in my community about this demonstration, they don't know anything about it. There's not been good communication to clinical primary care geriatrics providers in my state. There's been pretty good connections with home health services and nursing homes who have been very concerned about the demonstration and what it means for them. They've been very engaged in it. But clinical providers have not been that engaged, so there's a lot of education to do. I wanted to be able to advise my patients and families about what this is and how to choose a plan. And as we all know, integrated financing does not mean integrated care. As Renée pointed out, this could be just a way for the insurance companies to skim off some money, and they may not do the things that need to be done to make this really work. It's an opportunity for us to promote the things that we've all learned about in our training and have learned about through our colleagues who've done research on how to provide better care for older adults. The lessons I've learned, as I've mentioned, this is really complicated, and the complications are already being seen in Ohio. We started June 1st in my area. We started up in May in Northeast Ohio. Provider groups, particularly home health agencies, are already feeling like payments are delayed. They're not getting enough cash into their system. The health plans are having trouble operationalizing this. This is very complicated. One of the good things that happened in Ohio is our area agencies on aging went to the state Medicaid office and says, we want to be involved. And in my community, we have a wonderful area agency on aging. It already does a lot of care management for this population, particularly in the over 65 age group. And they are now partnering with Aetna and to a lesser extent with Molina in my community to do a lot of the care management. So some of the existing care management relationships that were already developed in my community are not being as disrupted as I was worried might happen. The work with the Ohio Consumer Voice for Integrated Care and Community Catalyst has been crucial for me to get engaged in this. I wouldn't have known where to start. And having my connections with them has allowed me to see what their priority issues are, to understand how I could be helpful. When I go to a meeting, they all are much more political and capable of asking the right questions, but sometimes they don't know what clinical questions to ask. And so it was an opportunity for me to be engaged. For example, in one of the places where I work, we have a very strong nurse practitioner presence in our nursing homes through the Optum Evercare plan, which has been great. And nursing home patients who are dual eligibles, many of them have a nurse practitioner that's been part of their care for years. And I was worried they would be thrown out because in my area, United Healthcare and Optum is not one of the plans. And bringing this up with Aetna, they decided to subcontract with Optum to let those nurses stay in place in the nursing homes, and I think that was a good decision on Aetna's part. There's a lot of things to pay attention to, some of which clinicians can understand better than maybe some of the consumer advocates. We don't know right now. Reimbursement's pretty stable in the demonstration. Networks are pretty broad. But it's pretty clear that to make this work over time, networks will have to be narrowed because you just can't manage all these people with so many different providers. And we'll have to monitor how that works. None of the health plans in Ohio that have taken this on really have experience with managing the whole range of services for this population of people. Some have more experience with Medicare, some more with Medicaid, but combining it all, it's really good that advocacy organizations are keeping an eye on these plans. And like I mentioned, my colleagues don't know much about it. So how can you get involved as geriatric providers? You can learn about what the status of demonstrations are in your state. As Renée pointed out, her website is a great resource. The Kaiser Family Foundation website is also a great resource. You can find out which advocacy organizations in your state are engaged. You can meet with your own health. One of the first things I did was met with my own health system to find out if we were even going to participate in the plan. I wasn't sure whether I'd actually have a provider role in the plans, and I was glad to know that my health system decided to contract with Aetna and Molina so that I can still take care of my patients and participate. And then you can attend meetings with consumer representatives, and there's lots of meetings. I've been spending a lot of time in virtual as well as on-site meetings. Meeting with the insurance plans has been fascinating. Meeting with the other providers, particularly in the disability community, and has been helpful. You can spread the word so that other people know what's happening and understand this. You can start looking for leverage points for where you can work with the health plans and the Medicaid offices in your state to bring in some of the models, like the GRACE model that Renée mentioned, to see if we can incorporate some of these models into the early years of these demonstrations. The demonstration's 3 years long. I don't think it's really long enough to actually implement. It's very complicated. I expect the first year is going to be just growing pains, and we might actually start seeing some actual improvements in the second and third year, but I hope the evaluation is not so rigorous that they decide that these demonstrations are not working too early in the process, because this is a major change in perspective to capitate this care and to try to do it better. It's going to take a while to work out. So there's a critical role, I think, that we can play, particularly if we partner up with consumer advocates like the groups led by Community Catalyst. I think we're much more likely to have an impact. It's been really helpful for me. I gather more information by working with these colleagues, and I feel like I actually have a role where I can be helpful to them. So I'm going to leave it there and see if we can have a conversation for the last few minutes and other questions that you might have. I'm going to turn it back over to John.
Thank you, Gregg, for that. I think it's very helpful to hear your perspective as a clinician, someone who was obviously very interested in the topic, but actually just started without a whole lot of expertise or knowledge, and has sort of in the course of a relatively modest amount of time turned into, I think, quite a powerful advocate, and certainly finding ways to make your geriatrics expertise available to folks in Ohio and indeed across the country. We do have a question from Margaret Woods. What stage is New York in this process? Have they begun as Ohio has? And I guess I would turn that to Renée, and unless
Sure.
Unless Gregg, you have some knowledge about what's going on in New York.
Go ahead, Renée.
Sure, I'm happy to. So New York is one of those states that has, in fact, signed a memorandum of understanding with CMS. The next milestone one of the next big milestones in launching their project is to reach an agreement around the contract that will exist between CMS, the state of New York, and the health plans that they end up choosing. And they've not chosen their health plans yet. They're still vetting them. That's underway. There's a draft that's circulated for comment, and we expect to see a final version of that soon, and a list of the plans that will be serving in the demonstration. In terms of the launch, right now it's set to launch with a voluntary enrollment period at the beginning of October of this year, so October 1, 2014. There'll be a brief voluntary enrollment period until the end of December, and then on January 1st they'll begin starting to passively enroll beneficiaries into those selected plans.
I see a question about what's happening in the states that have no demonstration projects, and it's a good question. first of all, this is the ACA has really created numerous opportunities and challenges for the states, and I think some states are struggling just to cope with Medicaid expansion or with their health exchanges, and so some states have just not moved into this process yet. As I mentioned before, this is a really complicated process to negotiate one of these demonstrations. Some states may have some things in place already that they're trying on their own, or they may be waiting to see how the demonstrations work out. As you saw from the map that Renée showed, some states entered into the discussions with CMS and then pulled out because it was just more than they could handle. One of the points I wanted to make is that this is a very bipartisan initiative. With all the negative vibes coming from the Republican Party about the ACA, my governor in Ohio, who's a relatively conservative Republican, thinks this is a great idea. And why does he think it's a great idea? Because his number one budget problem is his Medicaid budget. And this gives him a chance to try to cap that expense and to let the insurance companies try to manage the patients more effectively. So I can promise you he does not want to see this go away. But he also managed to bypass our state legislature and expand Medicaid in Ohio. And that's been, the expansion of Medicaid has been a huge effort, and the demonstration on top of that has been another huge effort. So I think our Medicaid office is really overwhelmed with change right now. I'm impressed with what they've been able to accomplish, but there are challenges.
Great. Thank you. We have a question from Carolyn Moretti. How long have the insurance companies agreed to be involved in this program? I'm wondering what will happen if it is too much for them to handle.
Renée, do you have a comment on that?
Yes, the three-way contracts they sign for I believe it's 1 year at a time. I want to double check on that to be sure, but I'm pretty sure that that's the case. There are lots of outs written into the three-way contract about not what happens if they don't meet the requirements of the contract. So things can change. There is also, an acknowledgement that things in the larger environment could change in terms of, the ACA, for instance. That would be a big one, and other things that could happen to maybe, figuring out the doc fix. That might change things. So, there is an opportunity to course correct along the way.
Great. Denise Dews would like us to show the map. Okay, let's see if I can get back to the map here. There we go. Okay, so that gives you a sense of the 26 states that are participating in some way, shape, or form, and the 24 that are not. Actually, to the earlier comment about Gregg's notion about sort of what's going on in Ohio, there was a question about sort of, we've been reading about this sort of the election in 2014. As you noted, it was very sort of hyper-partisan. Do you have a sense that elections, either at the state level in terms for governors or in the state legislative sort of arena or even the federal races, might have an impact on how this demonstration rolls out or how this work proceeds after November 2014?
Well, like I mentioned, I have met with the director of the state Medicaid Association in Washington, and they really see this as a very bipartisan topic. Bringing control over the costs the states have in caring for dual eligibles is an important thing to both Democrat and Republican governors. And I think trying to come up with strategies that allow for better care at lower cost following the ACA triple aim is something the governors are going to support and want to work on. So I don't think it's going to change. And even if there was a complete change in the administration in Washington in the next presidential election, this is completely out of the barn now. This is not going to go away. There's so many parts of the ACA will not go away, and this is one of them.
I agree with Gregg entirely. The delivery reforms aimed at focusing on sort of what known as the high cost, high need populations are a budget issue, and so it's quite a bipartisan issue. We will always have to stay involved to make sure that there is good oversight and good provisions that will work best for the people who are enrolled in them. But I do think that, like Gregg said, these are not going away.
Great, thanks. In the context, I know most of our listeners and participants today are in academic medical centers or in academic settings. Is there what for them as if they're indeed interested in kind of moving this forward? What is the sort of the value proposition, the argument, the rationale that they might make to colleagues in those settings to kind of engage them and bring them into this work?
Well, in most academic centers, I'm sure like mine, we are somewhat of a we're a provider of a lot of services to dual eligible beneficiaries of all ages. And in talking to providers in my institution, when they first hear about this integration, they figure, well, the insurance companies are taking over, this is going to be a bad thing. And I can't say that's not going to happen, but I try to put a more positive spin on it and encourage them to be open-minded about how this could be helpful to them. And so for individual providers, they will get from the health plans the name of the care manager that will be assigned to their patients who are in this plan. Each one of their patients who are dual eligibles will have a care manager. They will know how to reach that person electronically and by phone. They will have access to the care plans that are put together by the care plans. There'll be portals into the Aetna Molina websites where they can go in and find the care plans. And then when they have patients that they're struggling with that may go beyond the medical problems like we see so often in this population, I think there'll be an opportunity for them to test the system. So for example, if you have a client or a patient who is frequently in the emergency room, despite your best efforts, and you realize that part of the problem is they don't have enough support at home, I think if we call the care managers in these plans, they will have a strong incentive to get more help to that person in their home to reduce these trips to the emergency room, which may be related to anxiety or just uncertainty about how they are doing. There's opportunities to help the doctors do a better job caring for some of the more difficult patients. And I think up to now it's been hard to find people interested in helping us, so this may work.
Okay. Great. I think there's so there is a sort of a near-in sort of quite practical sort of benefit to and actually influence that this work will have on the care that our clinicians are providing.
If it doesn't, it's not going to be successful. I don't see how this can work without engaging particularly primary care and geriatrics providers to really work as a team with the care plans. Excellent.
And I guess I just one final question. We've got a minute or two here. For the folks, I'm looking at the map and I'm looking at my own state of Pennsylvania, New Jersey, Delaware, not far around. We're not participating in the demonstration. Renée, you noted a number of the names of the various advocacy groups in the 5 states that are involved. I suspect in the states that are orange or have or yellow, that it would be fairly easy to find the consumer group or a consumer group that was doing this kind of policy advocacy. How does one go about sort of, if one gets off the phone now and wants to kind of find a local or a statewide consumer advocacy group, how does one find that group or those people?
Well, I'd be happy, first of all, to take phone calls or emails from folks if they're interested in connecting with people in their state. We certainly know a lot of people in the state and in the states that are that are working on these demonstration projects. And if we don't, we'll find somebody. But there are some networks of advocates out there, including some that are organized by the National Senior Citizens Law Center that are doing a lot of great work out in California, but elsewhere as well. And so we can find an advocate that is working on this most likely.
And Renee, do you, there's a question or a request for your email address, but why don't we send that via email to everybody who's registered?
Sure.
That's all, rather than saying it out loud on the phone here.
Sure, that would be fine.
So we will do that. And then one last question. So here, if I'm interested, I want to get involved. What's the first thing besides writing an email to Renee and perhaps taking a look at the resources we're going to send out after the call? What's the first thing I can do when I get off the phone?
Well, I would suggest taking a look at the CMS website. It can be a little overwhelming, but there are a few things that are worth looking at. The CMS website, if you Google financial alignment demonstration, again it's financial alignment demonstration, you'll come up with a website that links to all sorts of information on each of the states. So you can look at fact sheets on each of the states. You can look at the memorandum of understanding if it exists. You could look at what the original proposal was if they don't have a memorandum of understanding yet. So I think that's a decent place to start if you wanted to look a little more in-depth in your state.
Well, along with the Community Catalyst website, which is great, and the Kaiser Family Foundation is monitoring this very closely too.
Very good. Those sound like excellent ways to start. The other thing, again, as we close here today, first of all, I want to thank Renee and Gregg for their excellent presentations and for getting us up to speed about how all of us can work better with consumer advocates to promote integrated care for dual eligible beneficiaries. It's an exciting piece of work and one on the policy level that's really moving in very exciting ways, and again, that would really benefit and is starting to really benefit from the expertise that geriatric providers, clinicians, experts are providing to that work. So again, on behalf of the Change Agents Initiative and the John A. Hartford Foundation and Community Catalyst, I want to thank them for their time and for their presentation today. As I noted, when we're done, we will send out more information to you along with the various website addresses and email addresses and contact information to help you get involved. And we also encourage you to take a look at changeagents365.org and the Change Agents community to, again, find additional information about this topic and to connect with others among the 2,700 folks or so in that community that are interested in these kinds of issues, and to find one another and to begin to share information that can help improve the care for these dual eligible beneficiaries, but also for older adults more generally. So again, today I want to thank everybody who's been on the phone today on behalf of the John A. Hartford Foundation, Community Catalyst, and the Hartford Change Agents. We very much appreciated your time, and we look forward to seeing you on our next webinar, which will likely take place later in the summer. Take care.